All right, all right. It's 11 a.m., so we're going to go ahead and kick things off. My name is Will Maddox. I'm a managing editor at DCEO Magazine in Dallas. I'm also the healthcare editor for the magazine. I spend most of my days writing about healthcare and the business of healthcare and organizations and public health. And over the last couple years, COVID has taken a little bit of my time, but I'm really excited to be here today. We have some great panelists, a really great discussion about healthcare access for at-risk populations. I want to let everyone know that the panel today will be recorded, so if you get pulled away or can't make it, you'll probably get sent a link where you can watch the whole thing. If you are a guest, an attendee, you won't be able to participate verbally, but you will via the chat function. If you have a question throughout, please shoot that into the chat function. So those questions will eventually get back to me, and we'll see if we can get those to our panelists at the end if we have time. So feel free to just put those in there as the panel goes. We're looking forward to it. It's my pleasure to thank today's host, Dr. Jerry Allison. He's a medical director of Molina Healthcare of Texas, and he has some words to kick things off. Here you go, Dr. Allison.
Hey, thank you, Will. And what a great audience and panel. I would like to welcome and thank you all for attending today's important discussion on innovative programs and partnerships to ultimately improve healthcare delivery to at-risk Texans. My role at Molina Healthcare of Texas is as medical director of our statewide mobile integrative health community paramedic program and partnerships. As such, I have the extreme privilege of working with some of our most incredible internal resources and our external partners, such as those on the panel today, to facilitate improved quality of life for some of our most vulnerable and at-risk members. We at Molina Healthcare are committed to improving and facilitating access to healthcare. A lot of great work has been done across the state over the past year. And the hope is that this panel lays out a little bit about where we've been, and more importantly, where we're going, with a focus on how various sectors, including healthcare, government, education, and community-based organizations, work together to improve access to healthcare in Texas. To help us get started, I would like to introduce Olga Rodriguez. She's the Chief of Staff and Associate Vice President at Texas A&M Health. I'd like to thank her for joining us to offer opening remarks about her work in healthcare delivery and how we can collaborate to better reach and improve the health of at-risk Texans.
Good morning, everyone, and thank you, Dr. Allison, for the introduction. I'm excited to be here today. This is one of the topics that I'm most passionate about and have worked on an array of issues over time. Just to give you a little bit more information about myself, I've spent about 20 years working on federal, state, nonprofit healthcare issues, anywhere from the White House Budget Office to the Health and Human Services Commission, in different roles in the Medicaid office and other places, the Department of State Health Services, with the FQHC Association, learning a great deal about treating the uninsured and other high-risk populations, as well as in my current role at Texas A&M Health Science Center, working not just with our clinics, but working with all our different colleges on workforce and other issues. As I mentioned, working with at-risk populations has been a key element of my career throughout these 20 years. There's been some really specific at-risk populations that we've looked at and done some really amazing work over the years in those different roles. I think the state of Texas is indeed a leader in addressing really unique aspects of children, of special populations, at-risk populations. And we've looked at that through many different lenses. So some examples include looking at foster care kids and their needs. The state and the health plan and others had a really good team in being the very first state to bring in foster care kids to managed care because of their unique needs, the transitional needs, and what was required. So that was one of the really amazing projects that Texas is able to provide the better coordinated care for foster care kids in the state of Texas. Another group that we targeted over the years were migrant children, especially the children that were traveling with their parents and had unique healthcare needs. And so, there were numerous avenues pursued with nonprofits, with community organizations, with the health plans on how is it that you improve the healthcare and the lives of migrant children in our different safety net programs and in our different healthcare systems. Another group really is looking at social determinants of health as it relates to low income pregnant women, children, and elderly. I think there's been a lot of great work over the years on what are those social determinants of health that each partner can participate in, whether it's the state Medicaid office, whether it's the Department of State Health Services, whether it's academic institutions that can come in and develop programs that can address social determinants of health and improve the overall health and lives of our communities. And another couple of other really good examples relate to children with special healthcare needs. We've had case management over the years, but how should case management work with children with special healthcare needs? How should it be structured? How should it be paid for? How should it be reviewed? And are the different models of case management improving the health of children with special healthcare needs and having them access to services appropriately and easily? And then finally, I think what's most pertinent on everybody's mind is COVID and what we have all done with COVID. So the Department of State Health Services partnered with Texas A&M Health to look at outreach and education for COVID immunization. And we've worked with over 100 different community-based organizations to really assess at the community level with those CBO community-based organizations that are in your neighborhood, why Texans are or are not getting the COVID-19 vaccine. And we found some really good information, especially at very high risk populations, hard to reach populations, where what we're learning really is it's more of a need of prioritization and what are some of their most immediate needs. So they're really focusing on food and shelter and those kinds of issues. And it's not that they're not focusing on COVID-19 vaccine, but they're focusing on those basic necessities first. So we've learned a great deal on those and ways to come into those communities and really address some of those needs. So some of the key things that I think I've learned over the years working on an array of projects with the different stakeholders is, number one, that you really can't do it alone, that you need a multitude of organizations, not just government like state and local and federal government, but you need healthcare partners, hospitals, different providers, health plans to help you in that. And then you also need people that are knowledgeable at the population level as well. And so what you also, I think there's also frustration in the community sometimes about the lack of understanding of the complexities of issues. And to really dig into the complexities of issues, and know that there's not just one solution for all of Texas, and even in each community, there's a multitude of solutions that can be implemented there as well. The third item is that's been really, really hammered into me over the years is to have the trust of the communities. You have to build it over time. It doesn't happen overnight. And it has to be by organization and institution. Texas communities are indeed unique. The same message, the same interventions, they just don't work across different communities. And to work on solutions with local leaders as well. And finally, and as important is the data that is needed. So community members need to know what's going on with interventions or expenditures that are happening in their communities. And so what is working, what's not working? Are you finding that things that are not working, that you shift and do things differently? And do you amend policies and procedures to better meet the needs of the community? So these are really important points that I've learned over the years that have only helped me be more effective in the different roles that I've been fortunate to have. So I look forward to listening to the rest of the panel members, and thank you so much for letting me share some of those insights. So I'll turn it back to you, Will.
All right. Thank you, Ms. Rodriguez, for helping us frame what is a very complex but important problem. So appreciate that so much. I also want to thank Dr. Allison and Molina Healthcare of Texas, along with its Molina Cares Accord, for bringing together today's expert panelists. I have a great group of people who are high up in organizations and right on the ground with patients, so they're going to be able to provide some great perspectives. So I'll introduce each panelist here. We have John Hawkins. He's president and CEO of the Texas Hospital Association. We have Robert Leavitt. He's the Mobile Integrated Health Coordinator at McKinney Fire Department. We have Dr. David A. Miramontes. He's the Medical Director at the San Antonio Fire Department and Associate Clinical Professor at UT Health San Antonio. And we also have Dr. Cynthia Weston. She's an Associate Professor at Texas A&M College of Nursing. So welcome, panelists. Looking forward to hearing from you all today. I'll kind of frame things up a little bit, and then we will hop into the questions. Texas, big state, also one that is growing quickly, right? We've added 4 million people over the last decade. At the same time, Texas ranks 42nd overall of all states in a recent measure of health system performance. That's not because we don't have great hospitals. We have some of the best in the country. A large part of that ranking is because it's difficult for a lot of our residents to access and afford the healthcare they need. Compounding the issue and driving up healthcare costs are a number of potentially preventable visits to the emergency rooms, some of which are not emergencies, but without insurance, you have nowhere else to go. Others of which can be treated upstream via primary care, via urgent care. A lot of these costly problems we end up with in the hospitals can be prevented. In fact, there's approximately 880,000 potentially preventable visits in Texas Medicaid and CHIP programs alone in 2020. And that cost to all of us, to taxpayers, was $378 million. So this conversation is going to dig into sort of addressing that issue. How do we help Texans get the care that they need when they need it, to help stabilize their health, to prevent problems downstream, particularly for those underserved and elderly populations. And that is not only a great thing for those patients, it also benefits the entire system and healthcare costs. I myself, I have a little personal stake in this game. My mom is a psychiatric nurse at a psychiatric emergency services in Austin, Texas, and is on the ground seeing vulnerable patients with mental health issues every day. So she is right there. My wife's also a pediatrician here in Dallas. And so she is also seeing these same vulnerable patients. So I'm honestly curious to learn more and excited about getting into today's panel. We're going to start with John. So the past 2 years, obviously been undeniably challenging for hospital systems across the country with COVID-19. Can you just start off by giving us an overview of what hospitals in Texas are seeing in terms of potentially preventable ER visits, and then how that's impacting staffing, access, and really the overall healthcare system? Can you start us off with that, please?
Yeah. Thanks, Will, and appreciate Molina for asking me to be a part of this this great discussion. So obviously, you did a great job teeing up the issue. Really, preventable ER admissions or inappropriate ER admissions have long been a challenge in the healthcare system, particularly in Texas. And frankly, COVID has just made that situation a lot worse. Really, when we look at the issue of non-emergent ER use, I think it really goes back to two issues. Number one, the fact that Texas still unfortunately leads the nation in the number of uninsured, probably more than 5 million citizens that are uninsured. Again, that's attributable to a lot of different factors. We're a state that has a pretty limited Medicaid program. Only recently did we extend postpartum coverage, but beyond a couple weeks to 6 months. Obviously, we're a state that has not chosen to expand Medicaid under the Affordable Care Act, which could potentially cover another 1.4, 1.5 million Texans. The fact that we're a border state, preponderance of small businesses, service businesses, which struggle to either provide coverage at all or provide it at an affordable rate. And so the uninsured continues to be a challenge. And again, as you pointed out, for a lot of those folks, seeking care in the ER really is the only option for them, which is not a good from a clinical standpoint, not good for outcomes, and not good for cost, as you've pointed out. And then I think the other big challenge is just the fragmentation, continued fragmentation of the system beyond the hospital walls. Obviously, I'll talk a little bit later about our 1115 waiver and how that's actually provided some incentives to build out infrastructure beyond the hospitals. Primary care is certainly something that's important, you mentioned. But I also know we're going to talk about behavioral health services. And when you look at a lot of folks that are boarding in the ER inappropriately or even readmissions, that's because of a lack of integrated behavioral health services out in the community. So that's real important. So really, those are the factors I think that are at play. COVID obviously has made that more of a challenge. If those external services are limited because of restrictions based on admissions due to COVID, I know we'll talk a lot about the workforce challenges that we're all seeing. And if you've got a nursing and an allied health shortage, that impacts throughput. It also impacts our ability to discharge patients if nursing facilities, home health, other subacute providers don't have staff. So all of that is really kind of the perfect storm to make these a challenge going forward.
Thank you. Yeah, I think you framed it up well. And one takeaway that I always have after these conversations is really that, it seems like some of the solutions that we're probably going to talk about are not only good for patients and the right thing to do and better for their health, they're also better for the finances of the state, tax dollars, spending as well. So that seems like a win-win. We're going to talk about some of the obstacles to that win-win, but yeah, I appreciate you sharing that with us. We're going to go to Dr. Weston next. Again, he's the Associate Dean for Clinical Outreach Affairs, as well as an Associate Professor at Texas A&M College of Nursing. So Dr. Weston, you're involved in both studying and getting to the root cause of why these populations are hard to reach, as well as why they are turning to emergency rooms unnecessarily. John touched on it, but I'd love for you to share a little bit with us about just how deep-rooted some of these issues are, how difficult are these folks to reach, how difficult is it to get them to not go to the ER, or do they have other options? Can you tell us a little about that?
Yeah, thank you for that question, Will. And the deep-rooted issue is lack of access to care, both primary care and mental health care. You know, primary care is the foundation for good health. It's through primary care that you receive immunizations, health screening, wellness checks, access to treatment for acute and chronic conditions. Access to primary care achieves healthy communities. It also reduces healthcare costs. It creates health equity. And currently, Texas is dead last in the 50 states in access and affordability of care. You referenced that, Will, in your introductory remarks. And when patients don't have access in an ambulatory care setting, meaning a clinic environment that's in the communities in which they live for primary care and mental health care services, the emergency department is their only access point. It's available 24/7, 365 days out of the year. So the best way to reduce emergency department overutilization is to keep people from becoming sick in the first place. And we do this by screening them and by giving them health maintenance, health promotion, disease prevention, safety education, vaccinations, really easy things so we can treat the conditions before they progress. And, you know, also we have 171 of our 254 counties in Texas that are rural, and rural areas have even more limited access to care. There's longer distances to travel for even the most basic of care. And as John already mentioned, Texas has the most uninsured citizens than any other state in the US. 1 in 5 Texans under age 65 don't have health insurance, and over 650,000 of those are children. So all of these factors, lack of access to care, our vast rural spaces with distances to travel to receive care, and the high rates of uninsured, that fosters emergency department overutilization for what would otherwise be addressed through primary care access and mental health care access.
Yeah, great point. And you know, you mentioned just that difficult accessing care. I always every once in a while when I'm writing story reporting, I will just Google doctor's offices and look at the map of the city and see where those access points are. And so often they are located in parts of town that are not full of at-risk populations. And so that's just one more hurdle, even within a city. You obviously bring up the rural side as well. So always super difficult. Next, we're going to go to Dr. Miramontes. So you've led numerous fire departments and agencies, including your current position as medical director of the San Antonio Fire Department. You all are first responders, you're first on the scene. Can you talk a little bit about what challenges you've seen firsthand in sort of connecting with these vulnerable populations? And then tell us about maybe some solutions. What has worked well for you all in connecting with those folks?
Well, great. Thank you for having me on. So our populations are what I call the NOTs: not insured, not documented, not housed, and not in recovery, that either from drug addiction or mental health. And unfortunately, what's the easy button when they can't get to the emergency room or the primary care physician? 911. That's the easy button. And so we'll go out and integrate with them. I have the top 10 things that we deal with our mobile integrated health programs that help to get these folks into care and get them off the 911 rolls and into primary care or specialty care. And the first one is they got to have a primary care physician. So even if an insurance company assigns them, many of these folks on Medicare, Medicaid, HMOs, or PPOs don't make contact with that PCP, so that when they're sick, they don't have that relationship. They can't get through the phone tree. I can't tell you how many times we've heard this. I can't get a hold of my primary care physician or the nurse. And so they end up calling 911 at 5 o'clock, exhausted. They don't have transportation. Their medical office or their medical home is not on a bus line. These are very simple but obvious barriers to care. They get delays getting appointments or delays getting referrals, delays getting DME because it has to be pre-approved. And God forbid you don't get your asthma medications refilled in time. And now you have an acute exacerbation and now you're calling 911. Remember, these folks are looking for immediate need gratification. And the ER or urgent care does that. Primary care, not so much. It's on a days to weeks time frame rather than an hours to days time frame. And even if they go to the ER or go with EMS, the communication with the primary care physician network is horrible. And this leads to this idea of, I'm supposed to be on this med, no this med, and med reconciliation gets all goofed up. So there's a mismatch about what the treating physician and what the primary care physician and the pharmacy has for this patient. So how do we overcome that? We use a fire-based model. You say, why firefighters? Well, firefighter paramedics are trusted members of the community. They're already in those areas of need every day, 911 calls. So they're recognizable to the community. And they're problem solvers by nature. They do things to get the job done on a minute to hour basis if they can, if they're given the tools to do that. In Texas, perfect. We have a delegated practice state. So paramedics can do pretty much anything that their medical director will allow them to do in the field. So for us, the fire-based model of problem solving, these high volume utilizers, folks that are navigated into care, it's a fire-based solution because the firefighter paramedics are trained, they're used to dealing with sick people, and they know the medical system and how to push them into the system that works for the patient.
All right, thank you. Yeah, that's super fascinating, and but I imagine also one more responsibility or several more responsibilities on top of kind of what their primary responsibility is in fighting fires. But glad that that system is working and that those connections to the community have an impact. We're going to stay in the fire department world and kick it over to Robert. So you are the mobile integrated health coordinator for McKinney Fire Department. One, I'm just curious what that means. What is that program, and how it's helped patients sort of navigate and connect to the local health system. And we'd love to hear about what you've learned from the community, how their response has been to the program.
Thank you very much. We started this program about 78 years ago. We just didn't really realize what the capacity would be when we first started. And when we first started, it was basically like the last one said is about, they were calling 911. That was actually their primary care, was to get into an MICU and go to the ED. They didn't have a primary physician. So what we started is we had frequently 911. We went and spoke to these people. We didn't really know them. We knew when they called 911, we put them in the back of the ambulance and we took them to the hospital. So now what happened is we end up being maybe their primary care physicians because we're going inside the house. We called it the old doctor's way when you used to go to the homes. And we figured out what their problems were. And their problems could be from one side to the other. And I'll give you an example. We had a patient that we went and saw her. She was calling 911 about 6-7 times a week. And what ended up happening is when we finally got to even know her and recognize her and what's going on, she had a bowl full of medicines. She didn't have prescription bottles. They're all in one bowl. And so we told her, we asked her, says, how did you know which ones to take? And she goes, I didn't. I just took one when I felt bad. So we finally figured out what was going on with her, pulled all these away from her. And now this lady now takes her medications like she's supposed to. And she'll actually call us when the medications aren't coming in. So we created a huge relationship with her. And so with McKinney, when we started this, it started that way with this 911. And then what we did is we had what's called firefighter referrals. And so what happens when our firefighters go out to the residences, they see something that's wrong, could be a fall hazard, or they need grab bars or something like that. And they would call us into our program and we would go out and do the evaluation for that one patient, for that one deal. So we carried these patients on and we normally would go anywhere, some be one time and we may see them 30 times. We didn't really have a time limit until when we finally realized what was going on with them. We fixed them. They became a better person, they became a better citizen. But the biggest things that we're having right now, as like I said, is transportation is huge for us. And some of our patients are having to drive 60 miles just to get to a CS specialist because we don't have a specialist right here in Collin County, which is really sad, but this is where the system is. We do point of care labs, so that helps. And that way we can talk to their endocrinologist or their cardiologist. And that seems to help out a bunch because that way we can change their medications at point of care, like everybody's been saying. So it's a really trying effort. It's still growing and we still change. We're now realizing that the homeless population is getting bigger here in Texas, and something that we didn't realize that we had even here in the city of McKinney. So it's something that we're working on too, because they have no care whatsoever. And so what they do is they go to the hospitals and to the ERs for help. So now we're starting to help them and getting a relationship built on that.
Yeah, sounds like quite an impact. And yeah, you mentioned sort of just being able to just connect those with someone that can provide that primary care, that can be regular, that can have a relationship with the patient. I think that goes a long way in addressing those upstream health problems. And both you and Dr. Miramontes mentioned sort of the challenge with medication, right? Whether it's not being able to get it or not being able to keep it organized, and just how that lack of adhering to your medication, it results in people, back in the hospital, back calling 911. And so just navigating that piece seems to be a huge part of this puzzle. Kind of sticking with the sort of solutions conversation, Dr. Weston, I'm going to turn to you. Can you tell us a little bit about some of what Texas A&M College of Nursing programs that you've seen have success in reaching some of these vulnerable populations?
Sure, and thank you for asking that. We've referenced the importance of primary care physicians and primary care providers, and we also have primary care nurse practitioners. In fact, 80% of the nurse practitioners prepared and educated, board certified in Texas, deliver primary care based on evidence-based guidelines, and that focus on health promotion, disease prevention, treatment of acute and chronic conditions. And we're fortunate to have a family nurse practitioner program here at Texas A&M. And we have a lot of creative and innovative faculty that have also developed some amazing clinical partnerships with some really impactful collaborations. One of those programs is addressing integrated behavioral health, which has already been referenced, the importance of that. We call this program In Cyber, with a nod to telehealth, which we also deliver through this program, and some virtual reality simulation, but it stands for Nurse-Led Collaborative Integrated Behavioral Health Rural Network. And we formed a partnership with the local mental health authority, Bluebonnet Trails Community Services, which services a lot of central Texas. It goes as far north as Llano and Marble Falls, and as far south as Gonzales. And they've had a comprehensive mental health program and substance use disorder treatment program, but they didn't have primary care. And through our collaboration, we provided family nurse practitioners in this integrated interprofessional patient-centered approach to deliver primary care to this very vulnerable population who also has significant emergency department utilization, often for those primary care sensitive conditions. By integrating these services, we've been able to comprehensively address the healthcare needs and impact the health outcomes and metrics for that population. We also have launched, it was referenced by Olga Rodriguez at the beginning, the importance of care for foster families, care for vulnerable young families. And we have a program called Nurse Family Partnership, which there's several throughout Texas. We've just launched this here at Texas A&M, which provides a bachelor's prepared registered nurse to a first-time mom and a low-income, vulnerable mother. And she follows that mother, or he follows that mother through pregnancy and then through the child's first 2 years of life. And we know that the outcomes of this program show that those families have better health outcomes, but better social determinants of health, higher education. In the long term, they've been tracked longitudinally. So that program is very important. We also have addressed through our nurse practitioner programs, comprehensive cancer screening, particularly in rural and underserved and unfunded populations or uninsured. Healthy Texas Women's will cover women's healthcare services up to age 44. But women that are age 45 to 64 in Texas have very limited access to cancer screening if they're uninsured or low income. And we're filling that gap with funding we've received through the Cancer Prevention and Research Institute of Texas, or CPRIT, in collaboration with some clinical partners like Houston Methodist and some other foundations. And we're taking our nurse practitioner teams into rural health clinics and sites, and doing comprehensive cancer screening for breast, cervical, colorectal, and liver cancer screening, some skin cancer screening prevention. All of these, we know that residents of rural areas that are oftentimes identified with cancer late, and therefore their outcomes are poor. So this is a way to fill that gap. And we also have a Center for Forensic Nursing Excellence here at Texas A&M that's going into rural areas and critical access hospitals and delivering trauma-informed care to survivors of sexual assault. And we've identified a need for a follow-up clinic for these survivors of sexual violence in rural areas, where we're launching a nurse practitioner clinic that will do follow-up care and navigate them to appropriate treatment to hopefully mitigate some of those long-term impacts of trauma, which we know a big part of that is anxiety and depression, but also chronic disease is a long-term impact of trauma experience. That's just a handful, and we just received funding. We're rolling this program out because I love the mobile paramedic program. This will be a mobile school-based clinic where we'll have nurse practitioners and registered nurses partnering with our rural school districts around the Brazos Valley. We have 6 rural school districts that have signed on to this program that have limited school nurse capability, but through that we'll go in and not only serve the students of these very rural schools, and some of these schools only have like 250 students, K through 12, very small rural school districts, and we're going to go in and deliver care not just to the students, but also the faculty, staff, and rural residents who are in need of care. We think these types of innovations and partnerships are a way to help fill that gap for care in Texas.
Yeah, quite a lot going on. If you need to be inspired or learn about an idea for reaching a vulnerable population, it sounds like A&M School of Nursing is a place to go and learn more. And the former teacher in me loves that these students are getting an opportunity to see that world. Obviously, they're helping people and helping them get better, but they're also being educated in that space. And I assume you're sending them off into the world with that perspective and understanding of, where the needs are, and wherever they end up, they probably have that experience with them. So I'm sure that's super powerful as well. That's great to hear. John, the next question is for you. We've been talking about vulnerable populations. Would love to hear kind of the health system hospital perspective on that. Can you tell us how individual hospitals or systems, municipalities, even statewide programs that you think are really having an impact on reaching these folks, and maybe deserve to be rolled out on a larger scale, more funding, and then what might that look like if we were to expand those programs?
Yeah, so great question. And really, I think the best example of building a system going forward comes out of our experience with the LEM 15 Medicaid transformation waiver that's been in place for more than 10 years now. Just a little bit of a backgrounder on the waiver. The waiver was actually implemented as a way to build out infrastructure, assuming the state was going to expand managed care. The waiver actually predates the Supreme Court decision, which actually made Medicaid expansion optional for states. So really the idea was to take the savings that we're generating from managed care in the Medicaid program and allow us to reinvest those savings into infrastructure building projects, many of which have already been talked about. And so, the waiver actually divided the state up into 19 different regions, put the public hospital as an anchor in most cases in those areas to help the hospitals partner with community organizations to address a lot of these issues. So that's been really a great thing. The challenge is, since the state has not expanded Medicaid, the federal government is trying to phase out the DSRIP projects statewide. And so really the challenge is to figure out the best way to replace them. But just a couple of examples. Again, I'll pick on Dallas since you're in that area. Parkland actually had a project where they partnered with the Texas A&M College of Dentistry. They built a new dental clinic in South Dallas. And again, when you look at a lot of these ER visits, it's because of lack of dental care. And so I think there's been some really good outcomes there with that project. Additionally, the Dallas County Health Department has an extensive program where they do actually educational outreach with a lot of community partners and employers to help deal with issues like diabetes. So if you can do some training related to pre-diabetes, you potentially avoid a lot of expensive hospitalization. So those are two, local examples, and there are many across the state. Many of them are partnerships with EMS and those type of agencies as well. From a statewide perspective, really, I'll give our Health and Human Services Commission credit. They're really trying to move our Medicaid program to more of a value-based program, much like the Medicare program. And so, for example, we have a hospital quality-based, potentially preventable readmission and complications program that actually exists in our Medicaid program to actually put part of the payment at risk for hospitals to give them the incentive to actually reduce complications and hospital-acquired infections. And I think that those types of programs, from a statewide perspective, are moving providers in the right way as far as reducing cost and improving care.
All right, thank you. And yeah, again, we talk about all these different angles and solutions, and there's a lot of programs out there, but it's encouraging to hear that everyone's working so hard to kind of reach these folks. Dr. Weston, we're going to come back to you, but Robert and Dr. Miramontes, don't sleep. We're going to get to you as well. You touched on this a little bit, and maybe I touched on it as well, but I'm curious, Dr. Weston, just to learn about sort of what Texas A&M is doing and other maybe educational institutions you've heard of in regard to just employing innovative teaching methods to help prepare this next generation just to meet these health gaps they're walking into. The situation we've been talking about, highest uninsured rate, lots of vulnerable populations, not expanded Medicaid, all these issues. What does that look like from a teacher's perspective in preparing these nurses for the healthcare environment? And how are y'all kind of working on those teaching methods?
Yes, so all of the programs that I mentioned are clinical education opportunities for our BSN nursing students and our family nurse practitioner students and other graduate nursing students as well. We have a Doctor of Nursing Practice, which is a doctoral degree that with a clinical focus where nurses address some of the problems in healthcare, quality, safety, increasing access, applying the evidence into practice where maybe there's a gap. So all of these programs that we have launched are clinical opportunities. We're incorporating some virtual reality simulation. We have a College of Architecture who goes to graduates end up going to work for Pixar and some of the movie industry, and they are incredible. And we worked with them to design some programs of ambulatory care sites, outpatient sites, patient homes, so that they have simulated environments for education and addressing population health and those social determinants of health. So it creates this framework and focus for our nursing graduates when they launch to address some of the complex needs in Texas. Nursing is the largest healthcare workforce, and by going into the schools, I mentioned our mobile school-based clinic that we're rolling out. We also intend to use that as a recruitment and introduction to the health professions in those K through 12 settings, because we believe that we need to continue to grow, not only educate the nurses of today and the healthcare workforce of today, but we also need to have that strong pipeline and pathway into the health professions on a continual basis. So those are some of the things that we're doing. We're always looking for more clinical opportunities, though. So anyone out there that has, please reach out.
Sure. And as I understand, I mean, we've also have a nursing shortage here, and one that's probably only going to get worse as people like my mom retire and need nurses themselves. And as I understand it, one sort of a chokehold on that is opportunities for clinical experience and getting those apprenticeships and that sort of thing. So,
and your mom is a psychiatric mental health nurse?
Yeah.
Integrated behavioral health program we have with Bluebonnet Trails, they have been very open to us creating a pathway forward for BSN registered nurses interested in psych mental health. We need a strong psych mental health nursing workforce, and they've worked for some intensive longitudinal nursing experiences for those. We allow our students to self-select into it, and it's caused retention of about 50% of those nursing students that are self-selecting into this program are going to work in psych mental health nursing. So those partnerships make a difference.
Yeah, that experience and good relationship with your mentor can go a long way, especially in recruiting those maybe difficult to recruit areas that aren't as attractive perhaps to the average nursing student. So appreciate that. Next question is for Robert. It's kind of sort of a two-parter. We're going to put you in charge of utilizing existing talent in EMT, fire, paramedics, and local communities. So what resources, how do we best utilize that talent to kind of connect folks in these vulnerable positions is the first part. And then how do we implement programs similar to what you have in McKinney?
Well, it always starts off the same way. We got these guys, we try to make them firefighters, but we got to write the EMICU first. So they start off as EMTs. And then when they get built up, then we turn them into paramedics. And then we go 2 or 3 years. And then this whole process with continuing education, we push them to other directions, because what they do is they see the real value of the patient care in itself, like when we're in the ambulance and we're treating these patients in the back. So now with this, we got critical care medics and we've got advanced practice paramedics, and these are education that we can do if they want to further their career, which is a huge help to the community, and that's where they come from. Because that's basically what it really is. If we get all the way down to the bottom of it, it's just basically taking care, because our mom and dads live in these cities, our family lives in these cities, and we end up taking care of these. What was your second question you want me to answer?
Just sort of what resources do if another fire department need to implement a program like what you have in McKinney?
It's expensive. That's one of the problems with it, is because the most expensive part of it is the person themselves. We can buy the pieces of equipment, we can buy the ISTAT machines and the equipment that goes along with this, but it's the individual to employ these. And so, but with that being said, is how do you put a price tag on it? And what I mean by that is when you change someone's life that probably wouldn't be here if they weren't inside this program and working with it. And so it gives them value, and that's where it comes from. But you have to employ and get into with your city and your city government, and have them understand it and educate them so they know what's going on and why we're spending these kind of money. Because once again, I keep saying that primary care physicians are far and few apart. They're in the ED now, so every patient wants to go to the ED because they know they can get immediate care. So what happens is when we finally get our employees and trained for this, and they get into doing this and spending the money for it, then they actually get to go inside these people's houses and change not only their health care, but the way they live and everything else. And this is where it all starts with it, right at the ground base of itself. But it's difficult, and it is. You got to have your own education and continue education. We're lucky here in McKinney that we've got a college right here that helps us out a bunch too. But it's expensive, just like anything else with healthcare.
Sure. And you mentioned obviously the impact on the individual and sort of the inability to put a value or a number value on that. That's obviously first and foremost. But if you are making that argument to the city government, county, state level, there also is the side of things that, hey, this cost up front, this intervention here is going to pay dividends down the line with reducing those ED visits, reducing severity of illness and that sort of thing. So there is a humanitarian and a fiscal argument to be made, it sounds like.
It is. In McKinney, we reduced it like almost by 50% for the ED visits. So that's a huge impact with them, right? And we also reduced 40% for the 911 volume for us for these patients that we had enrolled. So it's a huge, and all it was just basically education and get them on the right medications. And so we benefit all the way around from it. It's a 360 view.
Yeah, that's a great point. Thanks, John. Next question is for you. Would love to hear about, I know you talked about a couple earlier sort of, but if you have any other existing resources or programs that any hospital viewer connections should be aware of to help reach some of these at-risk populations and reduce some of these preventable visits, any other programs or resources come to mind that people should be aware of?
Yeah, one comes to mind. I'll put a quick plug in for the for Department of State Health Services. Actually, the Texas A&M initiative, which has been ongoing for several years, is actually a collaboration between Department of State Health Services and hospitals in the state to help with maternal mortality. We actually right now have 97% of the hospitals with birthing services in the state enrolled in this program. The program actually provides technical assistance to hospitals, creates care bundles to help deal with reducing obstetric hemorrhaging, improve care for women with opioid issues, and also reduce severe hypertension in pregnancy. And so those are, three areas where the data shows us that those create problems downstream. And so this program, I think, has been very effective in helping improve care in this area. THA actually convenes workshops across the state. We've actually been able to bring that back online now post-COVID, and this year we'll conduct meetings in 4 different areas of the state where we actually bring clinical staff together to share best practices and information to help improve care for maternal care in the state.
Great. Yeah, appreciate that. Dr. Miramontes, the next question is for you. There are many programs around the state and around the country that are really specifically designed to divert residents experiencing mental health emergencies from the emergency room or from jail. I know I've written about a program up here in Dallas called the Right Care, which is a partnership between social workers and the police to try and allow mental health professionals to kind of intervene in some of these situations. Given your involvement in a variety of task forces, working groups, and other experience, can you talk about any sort of best practices or programs you've seen to implement specifically in these mental health situations where 911 might be called and someone's suffering from a problem in that way? So how do we better serve these individuals? What does that look like? Can you talk a little bit about that?
Sure. So in the South Texas Regional Advisory Council, or STRAC, we have tackled this head on, but it's a partnership between our hospitals, our law enforcement, county, city agencies, and philanthropy. And we funded a number of initiatives through the South Texas Crisis Collaborative. And out of my 11 service lines, I have 11 MIH service lines in the San Antonio Fire Department. 3 of them are really laser focused on psychiatric issues. The first one is law enforcement navigation. So we saw a huge problem with ERs being overloaded, as other speakers have said, with psychiatric patients waiting for placement. So we flipped that on our head and we said, well, why are we taking them to the ER? Let's just take them directly to a psychiatric facility. And that's our law enforcement navigation program. One call, the cops all, that's all. And what we do here is we navigate our police officers. They call them MedCom. We have load sharing, load balancing throughout our psychiatric facilities, and the data speaks for itself. Out of 52 total law enforcement navigations just yesterday, 36 of them went directly to behavioral health. So that's quite a big number of patients who didn't go to the hospital. And you can see what the EMS to hospital numbers were, 2 of the 52. So we have flipped the way that we move patients through our system by taking them to the right place the first time with the right patient. We also have MIH services that focus on our psychiatric population, from 911 response, we have the core and the SMART teams that work as 911 responders with a police officer, a licensed paramedic, and a social worker. And they're taking 911 calls and trying to flip them into subacute calls, getting people navigated into clinics versus going to the emergency department. The other thing we have is the PIC team, Psych Intensive Care Coordination. So we have a team that's a law enforcement officer, a paramedic, and a social worker that work out of their own clinic with their own psychiatrist, with their own case manager, with their own nursing staff. And they manage the top 100 most expensive recalcitrant psychiatric patients. And they will do anything to keep them out of the hospital. If it means giving them their injection of Invega Sustenna at their house, tracking them down, getting them transportation, food, med reconciliation, whatever it takes. And then addressing the dual diagnosis patients with substance abuse programs like TTOR or Suboxone induction. Those are all key elements, but it takes a community. And this collaboration at South Texas showed us that we can manage these patients very effectively. Even at our homeless shelter, we have cut transports by 65% just by having a medic there on the night shift. So if you put key teams in the right place, the right time, you can leverage healthcare to the advantage of the patient, the hospital, the community, and the insurer, because we can do it at a much cheaper cost and burden to the community.
That's great, yeah, and I think those numbers kind of speak for themselves in regard to just diverting some of that, diverting some of those populations from the ED to other places where they can be served better. I'm going to end the discussion today with just a dialogue from all of our panelists about what you think is sort of the single most important factor just to reach at-risk populations across Texas. And whatever that factor is, tell me a little about what support you need from a policy perspective to make that happen. John, we're going to start with you, and then I'll let the other panelists hop in.
Yeah, so obviously from our perspective, the biggest issue is we've got to figure out a way to expand coverage in the state. And really, that's an opportunity to address three key populations. One, the moms postpartum. Again, we've expanded coverage 6 months. We need to go to full 12 months. I think the data backs that up clinically as well as that it's fiscally the right thing to do. We've got to deal with the working adults that are falling into the coverage gap because they make too much to qualify for Medicaid. They can't qualify for a subsidy in the federal exchange. We know that's 1.4 million Texans that we could very easily expand coverage to and potentially give them a medical home. We've already built the managed care infrastructure in our Medicaid program to deliver those services cost effectively. And then the third is behavioral health. Right now, most behavioral health services are straight general revenue. And if we were able to expand Medicaid, we could get a 90-10 match for a large portion of that population. So expanding coverage is key from THA's perspective.
All right. Appreciate that. Yeah, funding always important. Dr. Weston, you want to keep us going as far as the one key thing and what support it needs?
The key thing is access to care in Texas, and we're suffering a shortage of healthcare providers, but we're also making it more difficult to retain some of our current healthcare workforce because we do have a delegation requirement in Texas that puts us at a competitive disadvantage than more than half the country. For nurse practitioners in Texas, there's a requirement that you receive a delegation agreement with a physician before you can practice with what you've been trained and educated, board certified, licensed to do. 33 states, the Veteran Affairs Department, all branches of the military have removed that mandate. And every state that has removed that has increased access to care, particularly for at-risk and vulnerable populations, lower healthcare costs for the state and better healthcare outcomes for the populations of the state. So in Texas, nurse practitioners are having to close their practice or leave the state if a delegating physician dies, rendering them immediately ineligible to deliver care, or nurse practitioners are having to pay real hefty fees or even a percentage of their income just to enter into that contractual agreement with a physician. So we can have this no-cost solution immediately to increase access in our state. And unlike some of the other healthcare policy proposals that we're looking at, this one will not cost the state a penny. It'll just be removing a regulatory barrier. And then overnight, we can increase access with our existing workforce of primary care trained nurse practitioners, mental health trained nurse practitioners, reduce our costs to the healthcare system, and improve outcomes for patients in our communities.
Sure. Yeah, I think in just logic says if you have an access problem and a shortage problem, then removing barriers is one way to, and incentivizing maybe being another, but removing barriers being an important part of getting more people the care they need. So thank you for sharing. Dr. Miramontes, do you want to go next and kind of your one big thing and what support is needed to make it happen?
Helping patients navigate through the healthcare system, whether it be getting them into PCP, getting them transportation, helping them get through the hurdles. Our healthcare system is so complicated that a lot of our patients, especially are folks that have socioeconomic barriers. They need help getting through that system. The system is just way too complicated. Just to get a prescription filled or a wheelchair or any of those types of things, you just need a little help. And physician-directed paramedics can solve those issues quickly, effectively, and cost effectively, I might add, through the various fire departments. In my fire department, I don't tell my chief this, we're an EMS department that does fire very well. Over 85% of what we do is EMS. And so it's a great workforce that we can tap into to solve a lot of these community-based problems.
Okay, thank you. I'll check the attendee list and make sure Chief's not on there. Yeah, I appreciate you sharing that. And I can echo personally some of the difficult. I've been fortunate to be pretty healthy, but I'm in the middle of an MRI repair or ACL repair, and even for me, relatively knowledgeable, educated person, it's been difficult to call the right person. And does this cover that? And can I get a second opinion? It's not easy for anyone. So I think simplification would be key. Robert, can you tell us what kind of your one big solution would be and what support would be needed?
So the biggest problem that I run into most of the time is just basically lack of a specialist for our Medicaid patients. They have to travel long distances to go. And then, like I said, most of our patients end up going to Parkland. And the problem is navigating through Parkland is not easy either for these patients. And so just getting them the transportation, and if we had a specialist that was local, make life a lot easier for these patients, and they get the better care that they need.
All right, appreciate that. I know we have had a few questions come through, but we're also running out of time. So what I've been directed to let y'all know is if you have questions, drop them in, contact the group organizers, and those questions will get passed to the people that are needed, or maybe to me, and I'll write about it, who knows. But shoot those questions in and we'll work to answer those and get back to you as soon as we can. So I want to thank the panelists so much for your participation, for your insights. I feel like I learned a lot. I hope the guests did as well. I'd like to bring Dr. Allison back in the discussion. Can you finish up, just talk a little bit about, our host, Molina Healthcare of Texas, what its vision is for the next year, and how Molina is working to implement some of these programs or innovative programs to reach some of these at-risk folks?
Absolutely. Thank you, Will. And what a great discussion. What a great group of thought leaders. And I believe that we're all aligned in, what we believe can help our patients and our healthcare system. As both an emergency physician, a managed care medical director, and also a board member of the Woven Clinic, which is a health clinic that serves the underinsured. I do have a unique perspective, and I have to agree with a lot of the comments that were made today. We need to bring services to the vulnerable and at-risk members rather than expecting them to navigate the complex health system. We need to use non-traditional innovative roles for health professionals, such as the community paramedics that we've been talking about. But we also need compensation for these services, not just for ET3, but for providing care wherever that meets our members' immediate needs. Imagine where the healthcare system could be if we change our focus from costly specialty care to increasing incentives for primary care physicians, providing comprehensive care, including behavioral health, especially in the rural, remote, and underserved areas. As been stated, primary care and transportation are significant gaps in our system. We need to change the way we do business. We've got to stop doing what we've always done and expecting different results. So Molina Healthcare of Texas vision for the next year, as we continue to implement innovative programs to reach at-risk Texans, include increasing the depth and breadth of member-centric programs. We will reduce preventable ED visits and hospitalizations by assisting in the transition to home care for hospice patients to keep them from being discharged from the program, increasing behavioral health support, great programs like what Dr. Miramontes is talking about, and other programs as well. We will be closing quality gaps using our community paramedics. We'll be able to provide hospital at home, such as fluids or antibiotics, respiratory care, in-home testing, and other services, and institute remote patient monitoring. We will reduce food deserts and encourage food as medicine. Our members need healthy options. And we'll continue to expand services to at-risk members who may benefit from these programs. Our mobile integrative health and community paramedic programs create safe environments for our members. They strengthen social determinants of health. They expand behavioral health services. They reduce risk of overprescribing and medication confusion, another topic discussed as well, and assist in navigation of the health through the health system. This leads to improved health, and that leads to improved quality of life. And that allows our members to focus on their families, on their education, on their jobs and the economy. That's our vision for the next year. So again, thank you.
Appreciate that, Dr. Allison. And we've kind of come to the end. We're going to come back to you in a second, Dr. Allison, but we've come to the end of the panel, and we've touched on too many issues for me to really recap, but I think I was most struck just by the variety and number of solutions and people and programs working to reach these at-risk populations. Seems like they're making an impact where they are. It seems like one big hurdle is just, can we grow them? Can we expand them? Is there funding? Can we incentivize things to go that direction? And it's difficult, right? It's difficult to fight for these folks who are not calling their representatives and not as involved in the system and everything else. But we're thankful that all of you are out there working hard for them. So I appreciate everyone's comments and participation today. And I'm gonna kick it back to Dr. Allison for some closing remarks.
Hey, thank you. Thank you, Will. Again, thank you, panelists, and Will, for moderating such an important discussion. A great topic today, great discussion. Thank you, attendees. Really, thank you for taking your time this morning, for joining the discussion. Send in some questions. We'll be happy to answer those. And please visit molinacares.com, where you can learn more about Molina's work in the state. Again, thank you all. Bye now.